Okay, welcome back to the fourth of a series of 5 on clinical endocrinology by me, Dr. Pete Davis, consultant in diabetes and endocrinology at Sandwell Hospital. So a few things to mention before we plough into the content. Woody Allen famously said that the brain was his second favourite organ. So I guess we've got a whole stake in this, haven't we? We could have a lot of fun discussing some of these issues. Bear in mind the massive sort of age-related changes that we have, and the change in the function of the sex hormone system throughout our lives, from growth and development as children into young adults to our reproductive function, and the changes we see in older age. And then for the other part of our topic, disorders of calcium metabolism may be commonly seen in pretty sick people as inpatients, especially disorders associated with a high blood calcium level. If you look after surgical patients, sometimes they have a low blood calcium problem. I'm thinking, for example, of pancreatitis. But for the course of my talk here, we're really talking about medical conditions, and this is going to be related to medical emergencies. So primary hypogonadism, primary because we're talking about it being a problem with the gonads themselves. Now, if you think back to the principles of negative feedback, if you've got a system where the gland itself has failed, to try and correct that, the stimulatory hormones will go into overdrive. So in this case, the hormones we're talking about are going to be LH and FSH that go incredibly high. So if your gonads are failing and you're not making any sex hormone, it tends to be the LH which is going to go highest in that case. And this is the pattern that we see in a range of conditions. This is primary hypogonadism. If gonadotrophin levels were low, that would be what we would see in secondary hypogonadism, and this would be then a disorder of the pituitary or hypothalamus in particular. So, okay, primary hypogonadism then, what are you going to see? You're going to see low sex hormone levels, and you're going to see a variety of symptoms. In men, they can be quite hard to spot sometimes. The absence of periods in women makes this condition easier to diagnose in some ways. And there may be some other associated symptoms in women as well. So the commonest cause of this in women is of course going to be age-related, and it's going to be the menopause, often associated with those hot flashes. Premature menopause can occur as an autoimmune disease. So this is an example of a organ-specific autoimmune disease, and that will often go along with conditions like type 1 diabetes, thyroid disease, and so on. But there are some inherited genetic causes for this as well, and one of the commonest is the Turner syndrome, otherwise formerly known as gonadal dysgenesis, that will give this pattern of hormones. There's a parallel genetic condition in men too that gives rise to primary hypogonadism, and that's XXY syndrome, otherwise known as Klinefelter syndrome. The more mundane condition that occurs in men, it used to be mumps that caused this. It could also be trauma to the testicles. Any testicular damage can result in primary hypogonadism, and the treatment is to replace what you're missing. Advances in estrogen hormone replacement means that there are far safer ways to give estrogen than there ever were before. Giving estrogen orally can increase the chances of venous thromboembolism, but it's not seen to happen when estrogen is given through patches, for example. Estrogen replacement can increase the chance of breast cancer as well, and there are some positive health benefits from hormone replacement therapy that need to be offset against that. In men, we believe that sex hormone replacement increases the risk of the man having prostate cancer back to where that risk would have been if they had a normal level of testosterone rather than it being excessively elevated. So the rest of this presentation is on calcium homeostasis. So again, thinking about our principles of negative feedback, how do we maintain a normal calcium level in the blood? And it's all to do with these two pairs of glands on the back of the thyroid gland, the parathyroid glands. So the parathyroid glands produce parathyroid hormone, funnily enough, PTH to its friends, and PTH will lead to increased calcium absorption from the gut and resorption from the kidney, and it has the potential also to remove calcium from the skeleton if need be. And the system stays in a lovely self-regulated way, because within the parathyroid tissue there is an entity called the calcium sensing receptor. And the calcium sensing receptors operate rather like a thermostat, you can think. So there's a sort of set point around which a blood calcium is allowed to run, and it isn't allowed to go any higher or any lower. If the blood calcium is lower than it should be, PTH is increased. If the blood calcium goes above where it should be, PTH production gets switched off. So this is how the body regulates calcium levels in the blood through the parathyroid glands. So the common causes of high blood calcium we see, well, commonest of all that we see would be primary hyperparathyroidism, and we would estimate that occurs in probably somewhere around 3% of the population above the age of 60. It's quite a controversial area in endocrinology about exactly who requires specific treatment for primary hyperparathyroidism, because many patients remain asymptomatic and don't appear to have any consequence from this, and the primary treatment for it anyway would be neck surgery. So for many, particularly older patients, that's a step too far, and they end up managed conservatively. A different condition that can cause high blood calcium relates to what we said just earlier about the calcium sensing receptor. And there can be mutations of the calcium sensing receptor that change the set point. If you remember, we said there'd be a range of blood calcium around which blood calcium would be allowed to run, but there are different type of mutations that change that. There are what are called activating mutations, and by that it means that a much lower level of calcium would be sufficient to make the calcium sensing receptor feel the calcium's normal, and such people run low calcium levels. And then there are inactivating mutations that allow much higher levels of calcium to be happening in the blood before the receptor is stimulated, and they give rise to this condition called familial benign hypercalcaemia. So that's an inactivating mutation of the calcium sensing receptor. Patients typically run blood calciums of around 2.9 or 3.0, and they have very normal PTH levels going along with that, which is part of the way in which we would diagnose it. They also have low urinary calcium levels as well, which forms the other part of how we diagnose it. But the important thing about this is it's completely benign. It's not a disease state as such. There are no consequences for the patient, other than if it gets mistaken with this condition, people may end up having unnecessary neck surgery. What about malignant causes for high blood calcium? Well, sadly these occur from cancers which metastasize to bone. So typical ones to do this would be breast cancer, and it's also seen very commonly in lung cancer as well. So what happens is that this substance called PTH-related polypeptide, PTHrP, leads to the release of calcium from the bone through a sort of a local cytokine effect, and also a sort of a humoral, like a hormonal effect in the bloodstream as well. So common causes of hypercalcaemia in malignancy, PTH would be extremely low and measurable. In this condition, PTH is completely normal, and in this very common primary hyperparathyroidism, the PTH levels are usually very high. Rare causes of high blood calcium, we sometimes see it associated with an overactive thyroid, and it can occur with some drugs, particularly with thiazide diuretics. There are some other causes as well, and an extension to this might be to go away and come up with your own list of additional causes of high blood calcium. I mentioned earlier on that people with primary hyperparathyroidism often won't have any accompanying symptoms at all. But if people do have symptoms associated with high blood calcium, this little mnemonic helps you remember this: bones, stones, abdominal groans, psychic moans, and also the addition of high blood pressure as well can be added to that. So specifically, I would be asking people, for example, come into my clinic, do they make more urine than normal? Do they have to get up at night to make urine? Do they feel tired? Do they feel constipated? And then some more specific conditions like bone pain going along with that as well. So when you qualify and you're working as a foundation doctor, you will for sure need to be aware of the treatment of people with severe high blood calcium, which can be very dangerous. So we're talking here about typically people with malignant disease. There's very good evidence that if you vigorously hydrate with normal saline, 0.9% sodium chloride, this is a very effective way to bring the blood calcium down. If you combine that with a loop diuretic as well, that can work even better. Yeah, in most malignancies, using drugs that prevent PTHrP from removing calcium from the bones, this would be bisphosphonate drugs. These are a very effective way of turning off this process. There's a very special one that gets used, zolendronate. It's quite a powerful, this is ZOL. Zolendronate is a very powerful bisphosphonate that gets used in this condition. Permethrin was the original one that we had for the last few years. If blood calcium levels threaten life immediately, hemodialysis can be a way of removing calcium very, very fast. What about the flip side? What about low blood calcium problems? The typical cause for this would be vitamin D deficiency. We know vitamin D deficiency is incredibly common, particularly through the winter months. The pattern that you'd see here would be that blood calcium may not be all that affected, but in the context of a low or low normal blood calcium level, you really do see a screamingly high level of parathyroid hormone, because it's trying to correct the tendency of the body to have a low blood calcium level because of the low vitamin D. So you see much higher levels of PTH than you would, for example, in primary hyperparathyroidism. Sometimes you can find this is sort of older people living alone and boiling their vegetables and not getting enough vitamin D because of that. Sometimes it's because you think it's in ethnic groups who don't expose much of their skin to the light, but even in people who eat well and expose their skin to the light, this is really quite a common phenomenon. The symptoms of vitamin D deficiency are very characteristic. It can lead to a proximal myopathy, with difficulty getting out of the chair, difficulty getting up and down stairs, and bone and muscle pain. So I often think of this when I see Asian women with diabetes who quite frequently complain of what they say too much pain, and it's always very high in my mind to check out whether they may have severe vitamin D deficiency, because it is so easy to treat with vitamin D supplementation. A special case is renal disease, and this comes back to how our body activates vitamin D. The liver is responsible for 25 hydroxylation of vitamin D, and the kidney is responsible for position 1 hydroxylation. So in kidney disease, we often have to give a version called 1-alpha calcidol, which has the first position hydroxylation done for the precursor molecule, and then the liver can make adequate amounts of active vitamin D that way. One principle of vitamin D replacement is that you really do need to give the more simple type of vitamin D that will work. So I gave you this example of kidney disease where we needed to give a more specialist type, and that would come in a small number of micrograms per day. So that might be 1 or 1.5 micrograms per day. There is a version which is the active vitamin D, 125, and that gets given in nanograms, and it really shows how potent these molecules are. So if you can give a precursor form of vitamin D, and in this case you're giving a few thousand units of vitamin D a day, so we're talking sort of milligrams of a precursor, you're safer because the body will only make as much active vitamin D as it really needs. Whereas if you give these more complex molecules, it's very easy to over-treat somebody with vitamin D. We touched on surgery and care of people with acute pancreatitis, where calcium gets taken out of the system and made into sort of calcium soaps within the omentum in this condition, and calcium levels can get really very seriously low. There are conditions where the body doesn't make PTH. The commonest one, even though this is very rare, would be an autoimmune condition with destruction of the parathyroid glands. And there are some other rare conditions which I won't go into in much depth. We talked about the flip side of familial hypercalcaemia down to the calcium sensing receptor mutations. These are activating ones. The plus there, activating ones allow a much lower level of calcium to be tolerated. These are definitely not benign, and they can lead to calcification occurring in areas like kidney, what we call nephrocalcinosis, and also in the basal ganglia too, where it can give rise to movement disorders. So the treatment for this condition is quite specialist, but relies on drugs that help the body to keep from losing calcium through the kidney, drugs like thiazide diuretics. If you get a low blood calcium, you can have a number of symptoms and signs, and they're listed on this slide. There are features of neuromuscular irritability. Many of these named after famous physicians and surgeons from the past. In very serious low calcium levels, you need to give calcium intravenously in the form of calcium gluconate. That's most commonly seen as a complication after surgery when, for example, all 4 parathyroid glands are inadvertently removed when somebody has thyroid surgery. So that was a whistle-stop tour of hypogonadism and gonadal disease and calcium metabolism, and for the more common disorders of calcium metabolism. That's pretty much all the content I have for you on endocrinology for third-year medical students. The final installment is a short summary with some extension questions. So see you all there.